essential thrombocytosis. So essential thrombocytosis. So what are the other designations for this essential thrombocytosis? So the other designations include essential thrombocythemia and idiopathic thrombocytosis, primary thrombocytosis, and hemorrhagic thrombocythemia. Okay, so what are the other designations of essential thrombocytosis? So the other designations of essential thrombocytosis or essential thrombocythemia, it is also called as idiopathic thrombocytosis. It is also called as primary thrombocytosis, and it is also called as hemorrhagic thrombocythemia. So what is this? So this is a clonal hematopoietic stem cell disorder. Okay, so what is this? This is a clonal hematopoietic stem cell disorder. So this is associated with mutations. So what are the mutations in this disorder? The mutations in this disorder are JAK2, MPL or CALR. Okay, so what are the mutations in this disorder? The mutations in this disorder are JAK2, V617F, MPL or CALR. And how is this manifested? So this is manifested clinically by the overproduction of the platelets without a definable cause. So without any definable cause, there is a overproduction of the platelets. It's a clonal hematopoietic stem cell disorder. So what are the mutations? Mutations here are JAK2, V617F, MPL or CALR. And what is the incidence? It is 1 to 2 per 1 lakh, and this disorder, this has got a distinct female predominance. Okay, so what is the predominance? This disorder has got a female predominance. So canonical myeloproliferative neoplastic driver mutations, okay, they distinguish 90% of essential thrombocytosis patient from the more common non-clonal reactive forms of thrombocytosis. Okay, so there will be some canonical driver mutations in essential thrombocytosis patients in 90% of the essential thrombocytosis patient. Supposing mutation negative, okay, we have so these are all the mutations, okay, JAK2, MPL or CLR. Supposing we have a mutation negative essential thrombocytosis patient, okay, so this mutation negative essential thrombocytosis patient, they will have either uncommon MPL mutations or they'll have this JAK2 V617 expression limited to the platelets, or they'll be having a hereditary form of thrombocytosis. So this was considered once considered a disease of the elderly, okay, and once it was considered a disease of the elderly, and this was responsible for significant morbidity, okay. Why significant morbidity? Because of hemorrhage or thrombosis. And it is now clear that so this essential thrombocytosis can occur at any age in adults. Okay, so previously it was considered a disease of the elderly, but now it is clear that so this can occur at any age in adults, and often without any symptoms. Or so how can adults present without any symptoms, or there can be disturbances of hemostasis. There is an unexplained female predominance in contrast to primary myelofibrosis or the reactive form of thrombocytosis where no sex difference exists. So if we take this disorder, so in this disorder what can we see? We can see a unexplained female predominance. So this is in contrast to the primary myelofibrosis or the reactive forms of thrombocytosis. So in this primary myelofibrosis or reactive forms of thrombocytosis, there is no sex difference and no specific clonal marker is available. Okay, no specific clonal marker is available, and clinical and laboratory criteria have been proposed to distinguish essential thrombocytosis from other myeloproliferative neoplasms, which may also present with initially with isolated thrombocytosis, but they have different prognosis and therapies. Okay, there are no specific clonal markers available, and so we have to distinguish essential thrombocytosis, and we also have other myeloproliferative disorders, so they can also present with thrombocytosis, but what they'll be having this different prognosis and therapies. Okay, so these criteria, no, so they are useful in so because of these criteria, so they are useful in identifying the disorders. So which disorders we can identify? Chronic myeloid leukemia, polycythemia vera, primary myelofibrosis, or myelodysplasia. Okay, so all these disorders, no, they can masquerade as essential thrombocytosis. Okay, so these disorders, no, they can masquerade as essential thrombocytosis. Furthermore, as with idiopathic erythrocytosis, non-clonal benign forms of thrombocytosis exist. Okay, idiopathic erythrocytosis, in the same way, even benign forms of thrombocytosis also exist, that is hereditary overproduction of thrombopoietin, and those with non-canonical JAK2 driver mutations. So these are not widely recognized, okay, because we currently lack the diagnostic assays. Okay, so what happens in this disorder is there will be a hereditary overproduction of the thrombopoietin, and there also will be, and those with non-canonical JAK2 driver mutation. So these are not widely recognized because we currently lack all the diagnostic assays. So approximately 50% of essential thrombocytosis patients, no, they express which mutation? JAK2 V617F. Okay, so 50% of the essential thrombocytosis patient, they express JAK2 V617F. 30% have the mutations of CALR, okay, both type 1 and type 2, and 8% of these patients, they'll have the MPL mutations. So if they lack this canonical MP and driver mutation, they usually have got a benign prognosis. So these mutations are important. Okay, 50% will have this JAK2 V617F, 30% CALR mutations, and 8% MPL mutations. So patients lacking this canonical MP and driver mutations, they will have a benign prognosis. So what are the causes of thrombocytosis apart from essential thrombocytosis? So these are, so what are the different causes? So these are tissue inflammation or like collagen vascular disease or inflammatory bowel disease, or it could be malignancy or infection, or it could be due to myeloproliferative disorders like polycythemia vera, primary myelofibrosis, essential thrombocytosis, chronic myelogenous leukemia, and myelodysplastic disorders like Fico-Minor syndrome, idiopathic refractory sideroblastic anemia, post-splenectomy or hyposplenism, or because of hemorrhage, iron deficiency anemia. Okay, so we see this thrombocytosis, okay, in iron deficiency anemia, surgery and correction of vitamin B12 or folate deficiency, hemolysis or familial thrombopoietin overproduction, JAK2 or MPL mutations. Familial thrombopoietin overproduction, JAK2 or MPL mutations. So, what is the etiology of this essential thrombocytosis? Megakaryocytopoiesis and platelet production. So, this depends on the thrombopoietin and its receptor MPL. Okay, so if we take this essential thrombocytosis, so in the etiology, okay, so this I'll be discussing later.